The literature regarding use of various drugs in this patient population is somewhat limited because of the small number of the patients that we have. And what I mean by that is that prior to establishing the role of targeted therapies that we briefly discussed, obviously if a patient walked into the clinic with a BRAF mutation, many patients were treated with standard chemotherapy. Since majority of these patients are diagnosed with an adenocarcinoma, the standard treatment in this case was a combination of platinum plus pemetrexed, which we typically use in most of our patients with adenocarcinoma. There are both single institution and multi-institution publications looking into the outcome of patients who have been treated with a combination of the platinum plus pemetrexed, and also obviously in the era of immunotherapy, there have been single institution retrospective look at responses that these patients have had once treated with immunotherapy. I'd like to emphasize again that we don't necessarily have controlled randomized studies to look and sort of decide whether patients with BRAF mutations have a specific response to immunotherapy, chemotherapy. In terms of prognosis, again, having a small data set of patients worldwide it makes it difficult to have a complete set of data, but multiple studies now from different institutions and also some bigger groups in Europe collecting the data, it does appear that patients with BRAF mutation have a slightly better prognosis than patients without these mutations in terms of overall survival. Now, whether some of that is related to the fact that we have effective targeted therapies for these patients or not remains to be seen. For instance, in a paper that collected data from a couple of institutions in the US, patients with BRAF mutations who had received platinum plus pemetrexed at a PFS of about 6 months, which is fairly close to the group of patients that we see without any of the mutations, sort of suggesting that using chemotherapy is highly effective. But in the same data set, looking at patients who had, for instance, V600E, who had received targeted therapies, clearly the outcome of these patients were better compared to patients who, for whatever reason, never got the targeted therapies. There are also important clinical features that I think we sort of have to keep in mind. For instance, majority of patients with the V600 type of mutations, the class 1s that we briefly discussed, tend to be never smokers. So they might be healthier in general, or they might be younger than the average patient population who has a smoking history with adenocarcinoma or are former smokers. Other interesting clinical features suggest that patients with V600 type of mutations tend to have more sort of intrathoracic disease as opposed to the other subpopulations with BRAF that tend to have extrathoracic metastatic disease. And again, metastatic burden can play a role in response to therapy, duration of therapy, and how well a particular patient does. And in fact, if you, based on the published results, eliminate patients that have intrathoracic disease only, or those who got targeted therapies, the prognosis and survival and response to chemotherapy for the rest of the patient population sort of becomes the same. So I think paying attention to these clinical features and knowing what the smoking history is, or whether the patient has intrathoracic disease only or not, could have something to do with the prognosis that we are seeing. And again, at least in my view, in the absence of controlled randomized studies looking at the patient population, it's really difficult to be completely comfortable about the numbers and the data that we have out there. But again, the majority of the data for BRAF V600 suggests that A, targeted therapies are highly, highly effective, B, that these patients tend to have a better prognosis in general, again, perhaps due to the clinical features and perhaps to response to targeted therapies. Then the issue that we're facing now is that even when we do start with targeted therapy, again, at the time of prognosis, at the time of progression, if we do not find an actionable mutation based on repeat molecular testing, what do you do with these patients? There's been a lot of interest into looking at immunotherapy, for instance, because, again, as many of you are aware, there are issues for other patients on other targeted therapies when we go from one treatment to another, and there is definitely a lot of good data now that clearly indicates that, for instance, patients with EGFR mutations do not respond to immunotherapy as a single agent, and perhaps combinations would be better for that particular patient population. So the question then becomes, are BRAF patients in the same category, meaning that is it like patients with EGFR mutations where single agent immunotherapy might be ineffective? Again, we don't have randomized trials necessarily, but our colleagues in France had collected their data, and again, in a retrospective manner, looking at patients with BRAF mutations who had received immunotherapy, and it just appears, at least from these retrospective looks, that single-agent immunotherapy could give you the same response rate, roughly around 20%, than we get in patients without mutation. So again, we don't necessarily have trials to clearly show us this at this point, but probably these are coming. But the notion now is that immunotherapy could have some activity. There again is contradictory reports. There are reports that suggest that perhaps immunotherapy is not as effective. So again, these are the areas that we're still struggling with and we're trying to find answers to. But I would probably say in my practice, in the absence of a clinical trial, once a patient like this progresses through targeted therapy, I will have a serious discussion about not just chemotherapy, but even consider adding immunotherapy, again, in the absence of any absolute contraindications. But obviously, our preference would be to offer these patients clinical trials just so that we can learn from the experience and figure out what the right approach is for the management of these patients.